over half of the world's population lives in urban settings. So what do we mean by urban health, and what are some of the key challenges? A very quick opener for you.
Absolutely. So first of all, thank you for the invitation to be here today. So cities matter. As we heard most so eloquently, 3% of the world's territory equals 55% of the world's population. Cities define the world's health. No two cities are the same. And equally, within those cities, you see a huge array of different health outcomes. So ultimately, one of the key questions is, why is that, and what can we do about it? So essentially, there's a model of Health 3.0, which helps us start to think around the different types of interventions that can be used to nudge forward public health. So, if Health 1.0 was provision of clean water, of safe food, and Health 2.0 is essentially enabling people to have access to doctors and to actually cure themselves, Health 3.0 is this model where we look at a whole of society approach to ensure that individuals, communities, and countries take responsibility not only for their own, but each other's well-being to drive that forward.
Fantastic. So that's a really wide picture in terms of taking us from 1.0 to 3.0, and also explaining how no two cities are the same. Now, Hassan, living in the city of Abu Dhabi and coming from M42 to represent you, you're the Managing Director and Group CEO of M42. Give us an idea about the urban health challenges that you have an insight in terms of, and what needs to be the key things that need to be addressed.
Sure, thank you. You know, the UAE, and probably the majority of the individuals sitting in this room would testify to that, the UAE has been at the forefront of fighting COVID. Abu Dhabi played a significant role, specifically led by the two gentlemen sitting in front of me, His Excellency Abdurrahman, His Excellency Mansour. And going back to COVID, we didn't have a playbook, right? So it was something we were faced with. It was something we had to adapt to and to fight as we go. So to be able to stand up vaccine manufacturing, to be able to stand up vaccine testing, right, led by the Department of Health and the Ministry of Health, is something unprecedented. Which takes me to the next point. Some of the challenges that we're seeing, given our existence in 26 countries at the moment. First, the traditional way of undertaking healthcare is not sustainable. Not sustainable from multiple perspectives. One is healthcare professional shortages. The WHO clearly stated there will be a shortage of 10 million healthcare professionals by year 2030. We're seeing that, we're living that every single day, across the board, whether it being physicians or nurses as well. Two, unsustainable cost of providing traditional healthcare today. At the moment, what we're seeing is almost in every country, healthcare is 10% of the GDP of that specific country, and in fact 20% of the US GDP, which means if it keeps growing in that CAGR, it could break some economies if not controlled early on. Three, and as importantly, the environmental impact of healthcare. And to put things into perspective, if healthcare was a country, it would be the fourth or the fifth contributor to carbon emissions. Why? Mainly because at the moment, traditional healthcare sees patients, I wouldn't say unnecessarily, but could be prevented elsewhere other than hospitals, because of the amount of carbon dioxide of seeing these patients unnecessarily is not helping with that. Potentially, how do we address that going forward? It's important to look at it as health and not healthcare.
I think that's really profound, and I know there's so many threads that I want to pull on there that you've introduced for us there, Hassan, but to bring in my other panelists, so keeping that at the forefront, there is a distinction between health and healthcare. I think that's really powerful. You mentioned the shortage of healthcare professionals. Dr. Lujain, of course, with your frontline experience, it'd be brilliant to bring you in now about that main challenge when we speak about urban health.
Yeah, I would like to, and there's several urban health challenges, but I'd just like to quickly respond to his point regarding the shortage of physicians. It's true, there are 10 million shortage of healthcare professionals. But there's also an ongoing trend of unemployment among young physicians and other healthcare professionals. And that's really underlying the fragility of our healthcare systems. I mean, did you know that this 10 million, about half of that in Africa alone? So that can really see that also an equity in the distribution of that shortage, because we have rich countries that keep absorbing from a very poor pool of resources. So that's an issue to brain drain. So really address the resilience, the strength of healthcare system, and have a better and smarter healthcare system investments in terms of the timely, equal, and fair pay for the healthcare workers and healthcare environments. Other healthcare challenges I would like to stress on is in relation to non-communicable diseases that is really raising in urban cities due to poor diets, sedentary lifestyle, being exposed to soil, air, water contaminants that lead to several non-communicable diseases, including mental health. So we have increased rates of anxiety, depression, social isolation, and at the same time we have increased rate of infectious diseases because of overcrowding of cities like dengue or even given the COVID pandemic. The air pollution piece that was also raised by His Excellency is quite an important one. So let me highlight a solution.
I'm going to ask you to maybe hold on to the solution, because you're going to come on to solutions, and it's a riveting point. But you very astutely put the emphasis on diseases of all kinds, and I really want to bring in Dr. Seth at this moment, because of course you ran Gavi, the Vaccine Alliance, as well as co-founded COVAX. So at the heart of, you can actually give us that wonderful, profound insight. So the floor is yours, Dr. Seth, when we talk about urban challenges and that particular challenge to urban health.
So thank you so much, and it's really wonderful to be here with all of you. What we've heard already is, given what's happening, urban health is health. In the north, 80% of the population is living in urban centers, but in the south, it is rapidly rising, so globally 57%. So this is where we have to pay attention. And I think the challenge we have is we have to deal with the infectious disease challenges, which are still here. We heard Dr. Tedros talk about disease X moving forward. If I use my own experience, immunization, it is the most widely distributed health intervention. We get to more than 90% of the world with routine vaccination. That last 10% is absolutely critical from an equity point of view. That system, having health workers, is the early warning system that's there. And so what we have to do is think about both the diseases of infectious diseases, the challenge that will keep coming, and as we also heard, the non-communicable diseases that are rising and will account for 80 to 90% of the disease burden because of the excellent control that we've put in place for infectious diseases.
I think that's an excellent insight, and it really prepares us for our second panel discussion as well, which is going to delve into the necessity of the international legally binding agreement addressing the points that you've raised. Jeff, you've been waiting very patiently there, and I know that you've been speaking to me off stage about the insights that your organization is able to glean through the information and data you are able to collect when it comes to looking at urban health challenges.
Yeah, and I think to really frame it, and when we think about disasters occurs at the intersection of three variable sets. The hazard itself, which may be health in origin, like a pandemic, and may not be health in origin, like an earthquake or a storm or an infrastructure failure. But then it has to interact with two other variable sets: the vulnerability of our infrastructure, of our systems, of our people, and the capacity to cope of our communities and households. And health is always a major component to those vulnerabilities and those capacities to cope. So as we think about the 21st century urban landscape and the role of health and healthcare in that landscape, the role of these innovations is, are they actually contributing to broader resilience? Are we actually building resilience in so these innovations can extend and adapt to increasing frequency and extremities and the hazards we face? Or are we creating new vulnerabilities by creating things that require access to lifelines that could collapse in the event of a disaster?
So that's a very intriguing point about creating new vulnerabilities, as opposed to only thinking about the existing issues. Now, Dr. Lujain, I did interrupt you there, and I do want to ensure that we do focus primarily on the solutions. So please do elaborate your point, and then I'm going to bring in the rest of our panelists as we delve into solutions to some of the challenges that we've described.
Yeah, would love to. Just for the air pollution piece, there are around 37 cities, including the city of Dubai, that has signed the C40 clean air commitments, where they have committed to sustainable transport and use of the emissions. And here they see the importance of global collaboration to share experiences and lessons learned. In terms of the solution, and also from a healthcare and a physician's perspective, number one is education. So to include urban health in the medical and the healthcare curricula, including the postgraduate training to better understand the urban health challenges and trends that are emerging. The second one is in relation to new technologies. So healthcare professionals need to really embrace new technologies such as telemedicines, monitoring framework, information systems to really bridge the geographical barriers to be able to reach vulnerable populations. The third is preventive healthcare, primary healthcare. So we really need to focus on improving the lifestyle and the health of the people. So educating healthcare professionals on public health campaign, lifestyle interventions, and patient education to improve health and as a primary care preventions. And last but not least is multi-sectoral collaboration. Try to involve the healthcare professionals in setting solutions and setting policies when it comes to urban health and setting the interventions that actually impacts the health and well-being for all people.
And your emphasis there on the multi-sectoral echoes what His Excellency elaborated on very early on for our opening, the idea that we need to make this a holistic approach. There's no only one solution to everything. One key word that you mentioned there, and I think we're going to be speaking about this at length, is technology. I'm going to bring in Hassan now. M42, of course, being at the nexus of health, sustainability and technology. Please share your insights on this. And also, is technology the answer?
We believe it is. And we have taken multiple steps identifying what technology really means and how it could impact precision care and preventative care. Building on Dr. Lujain's point, we believe this is the future as well, to help break that traditional provision of care going forward. A few examples of things we have been doing in Abu Dhabi. One is the Population Genome Program. Two is, of course, data analytics. But three, which I would say is an enabler of everything we do, is artificial intelligence. If I just elaborate a little bit on the Population Genomic Program, it is important for us because it gives us a lot of insight to drive results that could, as a first step, make us understand what these rare genetic diseases mean, what it means for each and every individual. So
and in case anyone in the room isn't familiar, how would we sum this up, this particular genome project? The focus is?
Precision and prevention, which is the most important thing we're focusing on today. It leads us to pharmacogenomics as one of the outcomes of the exercise we're undergoing, right? Today, one size does not fit all. If you go to a provider, it is important for that provider to understand how your genome build looks like, to know whether paracetamol would work for you or it wouldn't. And if it doesn't, then something else could work. What does that do? It tackles two specific areas. One, going back to the cost increase, as opposed to duplication of prescription, as an example. We know from the first stance what's going to work and what's not going to work for you. But as importantly, making sure that people are owning their own health going forward. And this is where we focus on prevention and not treatment going forward too.
And that's a very powerful endorsement when we speak of prevention and not treatment. I know that with M42 there is an emphasis on people, not patients, so catching people early. Andrew, with Gallup's wide analysis across the world, you're able to follow trends, provide the data to back up the very key challenges that we've been illuminating so far. What are some of the solutions that Gallup are able to put forward, both on a government level and also on an organisational level?
Absolutely. So I suppose just to quickly reflect upon some of the comments around the promise of artificial intelligence. So, thank you. So for over a decade, Gallup's been supporting the World Bank measure global financial inclusion. So it's an SDG indicator, part of the G20 basic set of financial inclusion indicators. And so the reason why I mention this is because when we started that measurement journey over a decade ago, everyone was thinking, how are we going to move the needle in any kind of a significant way? So ultimately, at that point in time, 51% of the world's population had access to a bank account. You fast forward 13 years, and that figure is now 74%. You look at low and middle income countries, low income countries, that figure's gone from 10% to 40%. So quadrupled over that 10-year period, which is almost kind of unthinkable in terms of development terms. And what's been the driver of that? It's been technology. So you haven't necessarily had to create those bricks and mortar banks. You haven't needed to invest in that capital infrastructure of actually building those banks, having the security guards, the bank tellers, because digital has actually helped you overcome that. Essentially, it's created a leapfrogging of a previous state and provided access to many. That said, you actually see the fact that technology can compound pre-existing inequalities. So you look at the figures and you use the gender disaggregated data, and you actually see that women are 6% less likely to have a bank account than men. And so if we port this over and we think around similar models for AI and AI-enabled health, how do we ensure that whatever mechanisms and technologies that we're delivering in that field are actually being delivered in an equitable fashion, so that way everybody universally is benefiting from it, rather than us keeping these pockets who don't necessarily have access to those technologies.
And I think that's really key, because as well as being an enabler technology, you're also saying there are some risks that we need to mitigate. Beyond the risks that we often talk about, the ethical risks, you're actually saying you could bake in the inequalities into the solution that is being offered. So that's really important. Dr. Seth, I'm going to bring you in. We were speaking ahead of this panel, and you believe very passionately about the universality of healthcare and the disparities, if I may ask you to unpack that.
Well, as I mentioned before, the differentials between the mega cities that are forming in the South, there we see, 1 out of 3 people living in slums. And in the old days, when we talked about who was missed, we used to think about tukals in Africa, far out in the rural areas. But today, the largest percentage are people living in slums. And as we see climate change affecting, people are going to be moving, and therefore we're going to see more people moving into cities in non-planned communities, and this creates a risk. Now, what are some of the solutions? So on the 2 parts, first of all, we have to make sure that governments leave no one behind. And this is about bringing to that last mile. It's about having community health workers, other cadres that can reach out, and technology can be an enabler there. That's important. But how do we also make sure that governments are prepared? So the company I'm advising, SICPA, is working on a couple of things. One is to try to make sure that there's strong surveillance systems. I must say I'm very impressed. Yesterday I visited Abu Dhabi's wastewater program, where they are across Abu Dhabi looking at what pathogens exist. And this allows both deep genome analysis that can be done, but also looking for antimicrobial resistance and other challenges. If you can plug in, for example, doing that with aircraft, you can also look at what happens when new pathogens come in, and be able to have a prevention system set up that can help prepare you for the future, have a cockpit for the leaders to understand what's happening in terms of future health risks. On the chronic disease side, what's really critical is the proper tax policies. And this is going to be absolutely critical, having excise taxes on tobacco, on alcohol, on sugared soft drinks. and making sure that those go up over time so we can change the behavior of young people, because otherwise that tsunami of chronic disease will overwhelm the healthcare system that we talked about. And this is something that every government should be doing everywhere. There's forces that push on the opposite direction, but this is something that SICPA can help with.
Absolutely, and I think the key point that you made there was the wastewater surveillance, and I'm going to bring in Hassan in just a moment, but I know that Jeff's been patiently waiting. You gave me a brilliant insight in terms of your organisation and geospatial analysis being key to it. If you may share that with our audience in terms of a really good solution.
Yeah, absolutely, and so some of the work that we've been doing, and in particular in the United States, is leveraging census data, and so there are a variety of different indices. One of the most commonly used is with our National Centers for Disease Control and Prevention, Social Vulnerability Index. And this becomes really important because we can take census data and we can break it down into what we call census tracts, which are basically polygons drawn around about 4,000 people. And from there, you can run analyses and calculate things like housing insecurity, transportation insecurity. So if you're going to set up a vaccination clinic that's a 2-hour walk from a place with high transportation insecurity, people won't be able to access. You can model chronic disease burden, which is a big predictor of outcomes in a disaster situation. So it becomes a very powerful tool for planning blue sky, non-disaster healthcare resource deployment, but also, I like to say we don't know who is going to need help, but we know where is going to need help with this. Now, translating that into practice, we're maybe not as far along as we should be, but we're getting there. But the other piece that I would caution is a major prerequisite to this is good data. The good data is the backbone to all of these innovations. And in most developing environments, most developing countries, you don't have census data. We don't even have good population data, much less census tract level, detailed census data. So some of the most important investments when we look at global equity and when we look at really raising the bar so that everyone can achieve the promise of these technologies that are emerging is to invest in the very expensive, very tedious, very boring, from a public relations perspective, baseline architecture of data collection, data structuring to be able to serve as the basis for actually applying these innovations.
And as well as data being crucial in terms of how we provide universal health and health care, it's also a case of ensuring it's representative and it's gathered from across the globe as well, and there can be issues in that. I'm sure we're going to unpack that. But Hassan, I did mention a little bit more of an insight in terms of what's happening in Abu Dhabi with this wastewater surveillance. I think it would be a fantastic example to share with our audience. We often have our platforms here at the World Government Summit with an illustrious international panelist, but it's also wonderful to share what's happening here in the heart of the UAE.
Sure. So I think if I take the data point as a good segue to the specific example, and understanding what new pathogens mean and how we can deal with them. If I take that wastewater example as a specific one, and that's working closely with the regulator in Abu Dhabi, what it helped us do is avoid the spread of specific diseases to across Abu Dhabi. So the amount of insights we got from that not only helped with prevention, but helped with contamination.
And what was the timeline? Are we looking at something that was introduced very recently?
So everything I just shared as examples was introduced immediately and implemented immediately too. Right? It was mainly a reaction to things that we were seeing, but also us being proactive to avoid potential spreads. Abu Dhabi had one of the lowest spread of COVID rate across the world, mainly because, or thanks to, that wastewater exercise that we have undertaken in Abu Dhabi, because it helped us understand these zones where the disease was being spread, and it helped us contain it with that specific zone as opposed to spreading outside.
And I think at this moment we should give credit to His Excellency for the leadership and the team effort there. So a round of applause for this key example. I think that's really powerful. We've got 15 minutes on the clock. I want to ensure that each of our panelists, let's make this, we've had a chance to set the scene, we've had a chance to hear about your each individual expertise. Let's make it more dynamic, and I want you all to be diving in and me speaking less. Let's share some more key examples that work. Dr. Seth.
Can I just jump in, because I think you know, as we look at new pathogens, we also have to think about old pathogens and antimicrobial resistance. That's what the UN General Assembly is going to have a special session on. You know, the numbers are scary. We used to think we go in for an operation or a routine procedure, and of course, if you get infected with a bug that is resistant to all known antibiotics, you can go back to the fatality rates we had 100 years ago. And so again, these types of surveillance systems are going to be absolutely critical, but they bring up another issue, which is the idea of One Health, because of course the antibiotic use in humans is a challenge, but so is it in animals in the agricultural sector. And so what we need to be doing is bringing together these different sectors to try to solve these problems, and making sure that as we survey, we look at the risks that can move from one sector to another as part of the solutions. And lastly, just to say, the new tools we have, the technology, AI, the minister mentioned, is really extraordinary, because you can begin to use these tools to design now new classes of antibiotics, and even substances that aren't naturally known that can be very specific, and as long as they're carefully controlled, can increase the runway of the safety of our surgical procedures or the other engagements that are out there.
And yes.
I just want to build on one thing that you mentioned regarding the prevention of the non-communicable diseases, because you mentioned taxations on sugar, tobacco, and so on. I see these as more like a national measures rather than at the city level. We really need to empower the cities and the city leaders to take the action that they need, because I see them as a key catalyst actions. So bringing those actions a bit at a local level, I think it would be more powerful to focus on public procurement policies, as well as healthy and sustainable food environment interventions, looking at the type of diet, the type of food that is served at the city level, ensuring not just a healthy diet, but also nutritional and food security. Because as we said before, and many of the panelists have elaborated, there is increasingly social inequity, not just between cities, but also within within the cities themselves, leaving several vulnerable populations behind. So having a strong public procurement policies, ensuring not just the nutrition and the control of communicable diseases, but also addressing undernutrition, the hunger, the food security, and also the macronutrient hunger as well. And I think this is a key role that the cities can actually play when we look from a non-communicable diseases perspective. And adding to that is the encouragement of active lifestyle, to have the right space for exercise, sports, cycling, walking. Many cities around the world have already started doing that, which is great. I see the challenges in a region like the Gulf countries, giving the warm weather, especially me coming from Kuwait with 50 degrees in the summer, so it can be a bit challenging. So that's why it's important to include the urban designers into the conversation to mitigate those different strong factors, such as the temperature and the change in the climate. So we don't move toward indoor sedentary lifestyle, but more active lifestyle within the food environment that encourage people for healthy and nutritious food consumption.
I think that's a really powerful call to empower city leaders, urban designers, and bringing everybody on board. And I really appreciate you opening the landscape up right now and taking it beyond, for example, our focus on disease and technology so far, but also lifestyle changes, food security. I'm going to bring in Andrew at this point. Of course, with Gallup, you've been able to get some amazing research when it comes to well-being and this more holistic approach.
Absolutely. So Gallup's been measuring well-being at a global basis for over a decade and a half. So 142 countries year on year. And then we've also been supporting governments on a national level. But I suppose many of you may be unaware of the work we actually do on a city level. So essentially helping cities and leaders better understand their own populations, to understand what are some of the most effective interventions that they can deploy within their own populations. A meta-analysis by the What Works Centre for Wellbeing looked at a kind of cross-section of 52 papers. It looked at situations where community-based interventions don't work. And the most likely way of finding an intervention that does not work is imposing it from the top down, if you want to create community support and community buy-in. Which then points to this whole additional element around how do you actually create effective policies which the communities own themselves.
Which is music to our ears here, because of course it's the World Government Summit. So how do the policymakers make their policies stick?
And so it's as basic as having conversations with those populations. It's particularly unglamorous, it's not particularly sexy in today's kind of vocabulary, but focus groups, talking to groups of individuals to not only find out what they want, but find out the language that they use and the way that they interact as community groups, and working within that dynamic and that paradigm in order to really help create local ownership. So obviously, as an organization that works on global statistics, often we try and use our global statistics hammer to hammer everything down. But with some of our work on the Gallup Center for Black Voices, we've actually found that kind of participatory decisions around which metrics matter most to them, and then actually enabling those communities to own those metrics themselves can be incredibly powerful for actually driving that forward. And so if you look at our collaborations with the Blue Zones, that's where we've taken a core set of metrics, then supplemented those with additional metrics, thereby enabling each community to develop sets of interventions, sets of policies, whether with regard to food deserts, to address that kind of nutrition question, around to increase mobility, so walking trains for children to schools, those types of things which people can actually really feel that is theirs and that they can really take forward.
And I think those are really powerful examples for everyday life. I'm going to bring in
Yeah,
Jeff.
I just wanted to add in, I think that's a crucially important point. I know I talked previously about national level data to sort of look at census tracts, and I want to emphasize that that's a complement to the type of community engagement that we're talking about here, that there are nuances that are hidden from the data in terms of that. And actually, one of the great innovations of the last generation of healthcare is to push a lot of management into the community so people can be home. They don't have to be in an institution. But sustaining that in time of a disaster and sustaining that infrastructure, that community-based infrastructure, is how you keep pressure off of your healthcare system. I'll give just a very quick example. We had an ice storm in my home state of Connecticut, and it knocked out power. And then at the shelters, people started showing up with home ventilators, oxygen concentrators, things that they couldn't plug in. The shelter managers weren't from the healthcare side, and they said, whoa, I'm not touching that, go to the hospital. And of course, the hospital is already overwhelmed. Just because we've pushed healthcare into the communities doesn't mean the hospitals are empty. On a good day, they're not quite overflowing. So we learned very quickly that we needed to work with shelters, we needed to work with community-based institutions to be able to sustain those enabling forces that allow people to use those technologies and continue to care for themselves. And oftentimes it's the community-based institutions, it's faith-based institutions that are the most trusted, and that they're where people go to first for information as well as for resources.
I think those are really illuminating examples that show that it's actually not as straightforward when one conceives the solutions and implements them. It's actually these evidence-based examples show that it's that second level of potentially iterating those solutions. So between yourself, Andrew, and Jeff, those are really powerful examples. Hassan, I'm going to come back to you. You mentioned earlier, again, so let's take this idea of unpacking the solutions. You mentioned technology as an enabler, as a solution. But technology, of course, is expensive. We celebrated that great example happening here in Abu Dhabi, but also when we look at other countries, they aren't all necessarily on the same level to afford those interventions, technological interventions or others. So how can we perhaps scale up and ensure we can have global, universal solutions?
So technology is expensive to set up, but not as expensive to scale out. And that's a main focus area for us. So we always focus on scaling out as opposed to scaling up, simply because it is crucial for us to share the lessons learned of Abu Dhabi, of the United Arab Emirates, with the rest of the world. And the UAE has demonstrated multiple times in the past that they're able to do that and will continue to do that, only because we believe everything we have is to be shared. If I take, as an example, the genome program that we're running in Abu Dhabi, we sequence once, but we analyze multiple times. right? So standing up sequencing capabilities is not cheap, as everybody knows, but we do have, thankfully, we're blessed as a country to have the capabilities to stand up such programs, but also have the capabilities to be able to share them with the rest of the world. And we have been doing that with neighboring countries and elsewhere too. Everybody in the room probably knows 50% of the world population does not have access to healthcare, right? And this is where we come in, and we believe we take that as our fiduciary duty to share the experiences we have in Abu Dhabi with the rest of the world.
And yes, Dr. Seth, because I wanted to bring you in actually, because you've written about this idea of moving into an era of polyepidemics. I know that we are moving around many different subjects, but I want to make sure that we do hit this point before we conclude our panel. So,
yeah, but I do want to follow
yes.
Mr. Hassan, because I think that if we look at technology, first of all, we have to be thinking prevention, and we have to separate health from healthcare, because we tend to think of tertiary hospitals as healthcare, but bringing it into the houses, as we talked about, using prevention is the right way. So if you look at vaccine, it's a technology. It's expensive to make. It used to take a long time. Now during COVID, we certainly shortened it to 327 days, but then the challenge is how to scale out that technology and make it available. And so in the case of talking about 50% not having access to healthcare, that's the care and hospital side. As I mentioned before, vaccines over 90% access. And so the challenge is getting to that last bit and making sure that's available. Now, why is that important? Given climate change, given urbanization, given the destruction of natural habitats as these shifts in populations move, we will have more and more frequent epidemics. Some will be known causes, some will be unknown causes, which is why we have to be prepared, and it's also why we have to extend our reach to every single community. When we had the biggest outbreak of Ebola in the world in West Africa in 2014, it occurred in a community between 3 different countries that had no healthcare system, no surveillance system, and therefore it took an enormous amount of time to identify that it was Ebola, and that meant, of course, that it was able to spread and spin out of control. So these are some of the things that we have to do, and it connects right back to the urban households, because you may have a household or an urban community that is completely unserved in the middle of what is otherwise a wealthy and well taken care of community. And it's making sure we reach all of those that's going to be critical.
And thank you, Dr. Seth. You have connected it back to the central themes of this discussion, and also the polyepidemics insight is going to be a wonderful bridge into our next panel, which is due to begin very soon. But before I release my prestigious speakers from this stage, may I ask you all for one call to action when it comes to urban health? What would be your one main takeaway that you want the powerful policymakers in this room to take note of? Andrew, to begin with you.
So we did 160 focus groups in 15 countries around NCDs. Why haven't we made more progress? And part of the reason that we found was people don't understand the language that we're using. Ultimately, the health community has been talking to itself rather than to people. So if I've got one takeaway, try and understand the natural language people use for the problems that they're trying to address. And that is a key foundation to efficacy for any intervention.
Fantastic. Jeff, over to you.
Yeah, I would say adaptiveness in our systems is most critical. We face a lot of uncertainty in terms of the hazards that we face, but and we can't predict with precision what will happen, but we can absolutely frame that uncertainty. And in framing that uncertainty, we know the range of options that we may need to deploy. And if we can bake that flexibility, that range of options, into our deployment of technologies, we'll be much better suited to rise up to the challenges, to the hazards that we face for a more resilient and more equitable century and centuries thereafter.
So use language that is accessible and be adaptable and flexible. Dr. Seth?
A critical issue is going to be equity, leave no one behind, focus on prevention as a critical enabler, cost effectiveness of those interventions, and making sure that we reach everybody with both the tools to deal with the old problems, but also the new problems we're seeing.
So a universality approach there. Dr. Lee-Jane?
Urban health extends beyond healthcare and public health authorities. We really need to embrace collaboration across different sectors, across different disciplinaries, but also innovation and empathy. Only then we can have accelerated action and commitment to better understand the different people's needs towards healthier and more sustainable cities that leave no one behind.
To leave no one behind, echoing what the Minister began our wonderful forum here today. Hassan, yourself, your big call to action, the stage is yours. What would you be calling for?
Going back to the statement I started with, focus on health as opposed to healthcare, simply because the traditional healthcare that we see today is unsustainable. And technology is going to be the enabler of that going forward.
Well, this is a really promising panel which has given us so many solutions, unpacked them, looked at the complexities behind how we deliver them, how we iterate and stay flexible, but also how we provide a universal approach to a very universal problem. Thank you so much, Your Excellencies, distinguished guests. Please give my panelists a very big round of applause.